That's perfect. Thank you, Kevin. Yeah,
Hi.
I'm sorry I was a little bit late.
No problem. I'm just trying to turn my camera on.
Oh, no worries. So, how can I pronounce your last name?
Gochi.
Gochi. Okay.
Hmm?
Oh,
Where are you
Gochi.
from,
I'm,
Dr.
I'm
Gochi?
sorry, Gochi.
That's
Okay.
okay. No problem. I am from Los Angeles. Right now I am training in Oakland, California,
Oh, nice.
very close to San Francisco, and my parents are from El Salvador.
Mm-hmm. Perfect. So, if you don't mind, we could give a couple of minutes for people to start joining in. I know that Dr. Kassim is already here. He may join as a panelist if he is able to. Um, I don't know if Dr. Anna and Dr. Samuel are with you, Dr. Gochi, or not.
They are not. Unfortunately, I don't know them. I'm sorry.
Okay, no problem. They are also here in the meeting.
Okay.
So, oh yeah, that's it. Now we can see you.
Okay.
Perfect. We'll give everyone just a couple of minutes to have everyone ready.
You can see me and my presentation, correct?
Yeah.
Okay, awesome. I did make some stops along the presentation where I'm gonna ask questions from the audience. So I think those would be good points to sort of pause and, kind of have short little discussions.
Sure, that's awesome.
Okay.
Perfect.
Hello.
Hi, Dr. Aurelio.
Hey, hi. I'm here just in case.
Oh, perfect.
Thank you.
Oh, thank you. Dr. Vega is also here. Dr. Vega, are you able to join as a panelist today? I know that Dr. Aurelio and Dr. Kassim will be able to. It seems that Dr. Kassim will be able to as well. Dr. Kassim, are you there?
Yes, I am. Can you hear me?
Yeah, we can. Perfect. Thank you.
Oh, good.
All right. So it's well, at least in Brazil, it's 13:03. We are starting the meeting. The meeting now. We have the pleasure to have Dr. Andrea Gochi to present this case today. And unfortunately, Dr. April Mendoza, I don't know if she will be able to join, but she and Dr. Gochi prepared this case together to present here in this meeting. And the idea is, as always, to have a great discussion. Dr. Gochi will present the case, and we'll have some stops to discuss, and the panelists will be here to give their opinions and their insights. Dr. Andrea Gochi, feel free to start whenever you're ready, and I'll be here to help you to assist you with the moderation of the case.
Great. Thank you so much, Dr. Menigo. So, as mentioned, my name is Andrea. I'm currently a general surgery resident at UCSF East Bay. We practice at Highland Hospital in Oakland, California, and I'm currently completing my dedicated research time focused on trauma research and trauma outcomes. It's an honor to be here presenting to you all today. at the International Trauma Teleground Rounds. And I'll be sharing a case today that really exemplifies the challenges of managing a patient with multi-system trauma, as well as importantly, controlling pelvic hemorrhage, responding to blunt aortic injury, all in the setting of a high energy mechanism and a resource conscious environment, which I will be discussing shortly. And I hope that this case sparks a lot of discussion and that the principles that we applied here can be utilized anywhere where anybody might practice. I do want to give a shout out to Dr. Gutierrez. He is an attending at my institution and he is here present as well today. We have no disclosures. So these are just quickly our learning objectives. Oh, did I stop sharing?
No, we can see it.
Okay, great, thank you. Here are our learning objectives for today. We're going to review the clinical indicators and imaging findings consistent with hemorrhage and pelvic fractures. We're going to describe the management strategies for blunt thoracic aortic injury, and also throughout this whole case, apply trauma resuscitation principles in patients with multi-system injuries. So I'd like to start off with giving some context. This is Highland Hospital. It's a level 1 trauma center in Oakland, California. We serve a high acuity, underinsured patient population. And even though we are an urban environment, we often operate with many different constraints, such as limited consultant availability. Sometimes we run into imaging bottlenecks, and we have very high volume trauma. However, regardless of constrained resources, we still manage to have very strong interdisciplinary coordination, streamlined processes, and all of these things to be able to provide excellent trauma care to our patients. So with all of this said, I'd like to start off with our case introduction. Our patient is a young, about 31-year-old male who jumped from a 40-foot overpass in what is believed to be a suicide attempt. The ring down from EMS was that his pre-hospital GCS was 9. Vitals are seen there, displayed on the screen. And so I'd like to stop here and pause and sort of hear from the audience what goes through your mind when you hear a hospital ring down like this, and what's your initial mental checklist? If anyone would like to.
All right, let's start then. Dr. Kassim, do you want to jump in?
Good morning. So when you hear a story of somebody jumping from 40 feet overpass, that is just not critical height, it is double critical height, according to the classification from UCLA Trauma Center. They say if somebody jumps from 20 feet, is critical height, and for children is 10 feet. And when he's jumping 40 feet, is double critical. So you can expect severe trauma to every system that is possible, from head to the cervical spine, the rib cage, abdomen, pelvis, both limbs, especially calcaneal bones, and then inside, of course, other organs will be involved. And number one on this would be aortic injury, especially as the isthmus of the thoracic aorta and the arch just distal to the subclavian. And that would be where most of the injuries occur, like 70%, and below in the actual thoracic aorta, there's only about 20%. So you have multi-system injury, and the patient, if he is not resuscitated appropriately, he will die. But anyhow, more than 80% of this patient will die at the time of the accident are on the scene, only 20% will show up at the hospital, and of the 20%, another 10% will die in the hospital. So you are there to save about 10% of this population who commit suicide by jumping from overpasses. Thank you.
That's great. Thank you, Dr. Kassim. Dr. Aurelio,
Yes.
considering this case, would you agree with Dr. Kassim? Because it seems that, I mean, can this patient have such an injury despite his initial vitals? What are your recommendations to address this?
Yes, several comments. I agree 100% with Dr. Sim said. But I want to add it that in my 40 years experience doing exclusively trauma, and so many years, 30 years I spent in shock trauma, I saw, and I was involved in at least more than 100 cases myself. I only saw one patient. I know is one of the mechanisms of rupture aorta is falling for high altitude, vertical deceleration. And I only saw one patient who was a glider. That's a gliding. That's what these people who jump in those things and the thing cut. So he fell for high altitude. I think it was more than 40. And he has a rupture aorta. We saved him, but the point is, it is a mechanism. But Dr. Sim is not the most common mechanism. It usually, it's AP deceleration, whatever. But so we have to agree that in addition to, he enumerated perfectly all the, the fractures, the spine, all the organs damaged. As a matter of fact, Dr. Scalea wrote a paper once upon a time on jumping from high altitude. And one of my students from Milano, I forgot the name now, the Italian guy, wrote a paper in Milano. It's very common people jump from bridges. I don't know what's wrong with the Milanese, they jump from bridges. And many of them has rupture aorta. So conclusion, rupture aorta is one of the mechanisms you have to think about it. Obviously, first in the rupture aorta, we think about all the other mechanisms. And one of the things I will be very concerned, this is not written in the books, that I noticed that when the patient comes with this suspicious and the blood pressure go to normal to lower, normal to lower, normal to lower, this fluctuation is not written in any book as far as I know. It's an observation I did in 40 years. I think that immediately I'm thinking about rupture aorta. That's the mechanism, going down until one moment go down completely and doesn't go up. So that's my commentary about that.
Great.
That's great. Thank you, Dr. Aurelio. So, Dr. Gochi, I think you can move on.
Thank you so much. I really appreciate everybody's insight, everybody's feedback. So I'll be moving on to the trauma bay. So when the patient arrived to the trauma bay, we began with our structured primary survey following the ABCDE approach. As you can see in the slide, on evaluation, the patient's airway was patent. He did have some agonal breathing, but there were no signs of crepitus. Circulation, he had pulses present, had access in one of his arms. However, his GCS was about a 3, and he had evidence of a blown pupil on the right side. FAST was done and revealed absent lung sounds bilaterally. And so at this point, I sort of wanted to take a poll of what the next steps would be for a patient with these findings.
That's great. Let's switch sides now. Dr. Aurelio, what are your thoughts?
Yeah, I mean, now the thing complicated. This patient has a head injury. One thing come to my mind was reading the other day, Remember that we always trying to do this is called the acceptable hypotension, whatever is the other English name, and this kind of patient with head injury, you have to be very careful. You cannot do this hypotension business because, the brain needs volemia and oxygenation. So you drop the pressure because you want to keep low blood pressure. Maybe in this case it would be good if you know in advance that you get as a rupture aorta, you don't want to increase the blood pressure. But on the other side, if you keep the pressure low on purpose, you can affect the brain. So this is going to be a quandary here.
Great. Dr. Kassim, any thoughts?
I think the first line of treatment for this patient is access to his airway. you have to intubate this patient irrespective of what his diagnosis is going to be. Sure, he has a blown pupil, which indicates he has a cerebral injury, and he may be hypotensive due to volume loss, but the priority is airway, because he is not breathing at this moment.
Dr. Gochi, do you have any images of the fast?
Unfortunately, we don't have images of the fast, but I do have subsequent images.
Perfect. And what about the abdominal part of the fast? Was it negative?
The abdominal part of the fast was negative, yes.
Perfect. All right. I think you can move on.
Can I make a commentary here, which is very important?
Sure.
Recently people in a very rational, I agree with 30 way, they want to change those ABC and CAB, PPC, different levels, But this is the case, at 3 o'clock in the morning, this patient needs their way, and start circulation before. The reality is when you trauma center, there are people who put in their lines at the same time, the IVs at the same time, somebody's intubating the patient. So I want to emphasize what Doctor said, the airway, you cannot go, let's do the circulation first and then airway. This is when you are alone and you don't have, but you have 2-3 people there, anesthesiologists. The patient definitely need airway. I'm not going to say, let me start IV first. And they have to be very careful. Younger people can misinterpret it. You don't go that way in reality, in real life. Go ahead.
Thank you, Dr. Aurelio.
Thank you, Dr. Cass and Dr. Rodriguez. That's exactly correct. We proceeded to intubate with rapid sequence intubation. Bilateral chest tubes were also placed given the findings from the FAST, and central line access was obtained. And I do want to highlight the fact that some of these things could be happening simultaneously after the airway is secured. Somebody, bilateral chest tubes are going in at the same time while somebody's working on central line access. So I do want to thank you for specifically mentioning that, because that is the reality of when we're in the trauma bay, when someone's undergoing aggressive resuscitation. So thank you. So this is chest x-ray obtained after a patient was intubated. You can see the endotracheal tube here, and you can see bilateral chest tubes here. So once the primary survey was complete and initial stabilization was underway, our focus then shifted to resuscitation, specifically activating our massive transfusion protocol, as well as early TXA administration. I wanted to highlight our MTP process at Highland, because I know it can vary across different institutions, but at our institution, our MTP protocol is such that the trauma attending will activate MTP whenever they, this can be based either on hemodynamics or injury pattern, but typically it's the attending that will activate it. And once it's activated, our first cooler will contain 2 units of packed red blood cells, 2 units of FFP. Blood bank, a representative from blood bank is typically there during the trauma activation. And we're receiving coolers every 30 minutes or so with these ratios until MTP is discontinued by the attending. And at about every second or third cooler, we get a 6-pack of platelets because we do want to maintain that 1-to-1-to-1 transfusion. And lastly, regarding TXA, at this time, it really depends on whether the patient has received TXA in the field. If they have received it in the field, then we will administer it later. Otherwise, if no TXA has been administered in the field, we typically give 2 grams up front once the patient is in the trauma bay. And this is typically directed by our trauma attending. At this point, does anyone want to share how MTP protocol works at their hospital or I can keep moving. It just depends if anyone wants to chime in.
Can I ask a question, Dr. Gochi? And it certainly is aligned with Dr. Simaj. I don't know if I'm pronouncing correctly. I'm sorry, Dr. Simaj. If
It's
do you
okay.
have any perfect. Do you have any parts in Highland that you have whole blood for resuscitation?
That's a great question. I will need to find out. Dr. Gutierrez, do you know if we have whole blood at Highland right now?
We don't have access to whole blood right now, unfortunately. So we have to do component-based balanced resuscitation.
Thank you.
Perfect. Thank you, Dr. Simaj. I think it answers your question as well. All right.
So moving on.
Can we ask a question here to the audience?
Sure.
Yeah, of course, we are talking these days, whole blood is the ideal, correct? We all agree with that. But the question is about tranexamic acid. I was reading recently, I am now in practice for a few years. So the tranexamic was important, given pre-hospitary, then 8 hours, give it the other one. But now they're questioning, I think, that when patient with head injury, anybody want to make a comment? Everybody reading more clearly than I read the question about if it's good or bad given a tranexamic, or have to be careful in patient with head injury bleeding. Any comments?
I would definitely give TXA to this patient. I think the patient has 2 indications for TXA, hemorrhage and intracranial hemorrhage or injury. I think there's been data, in particular the CRASH 3 trial, that has shown mortality benefit to giving TXA for head injury patients with any intracranial hemorrhage on CT scan, even if they have a GCS greater than 12. So I would give it for that reason, but also for the potential for hemorrhage in this case.
Thank you for the clarification, doctor.
That's great. Any other comments on the TXA? Let me see, Dr. Kasim, any comments on the TXA?
I think we get hung up on TXA a little too much in trauma care. I think there are other things that you need to attend to this patient. And if the patient did receive TXA at the scene of the accident, well and good. By the time he comes to the trauma bay, if he's passed more than a certain number of hours, I'm told it is 4 hours, you can forego it. But if not, if you are one of those who are gung-ho on giving TXA, go ahead and give it and forget it.
Yeah, I don't want to be politically incorrect, but I'm famous for being politically incorrect. But I had the same feelings, I think it's age, my 82 years old, that I think we start talking about TSH, tranexamic acid, like we don't mention that you are not a trauma surgeon. We know the indication, but it's not that the patient have to have tranexamic acid, otherwise doesn't die, or doesn't live. So be careful. In this case, we agree has to have it.
Yeah, perfect. Dr. Gochi, you may move on.
Thank you. So with MTP activated and TXA administered, we continued onward with our resuscitation, and we moved on to performing a more thorough secondary survey to identify any further injuries. Secondary survey revealed a left lower extremity deformity, as well as tachycardia and sort of dropping blood pressure. We had lab studies that were sent. MTP TXA is running. So at this point, we were concerned about hemorrhage, and we weren't entirely sure where it was. I previously showed the chest x-ray, which did not reveal any evidence of hemothorax. As previously mentioned, the FAST did not have any obvious blood in the abdomen. And so our next consideration was the pelvis. Here,
Can I ask you a question, Doctor? I'm sorry to interrupt.
no
What do
problem.
you think about the chest X-ray? Doctors McKean talk about a rupture aorta. They say that chest X-ray to you look as an abnormal aortic node, abnormal descending aorta, AP pulmonary windows, all the criteria for diagnosing rupture aorta in the old days. Today we have CT, it's all the problem. But do you notice anything? It seems like the aortic now looks pretty good, right?
Yeah, immediately glancing at this in the trauma bay, the suspicion for any injury in the chest is, I would say, moderate given the mechanism of injury. But looking at the chest X-ray, there's nothing that significantly stands out that would prompt me to
Particular rupture aorta, correct?
correct.
Although I would like to clarify something. 10%, since doctor is mentioned percentage, 10% of patients with rupture aorta in the old days found out they have normal chest X-ray initially. You have to remember that. Not all the people with rupture aorta, majority has abnormal chest X-ray, but 10% can be completely normal chest X-ray.
Yes, thank you so much for bringing that up. I will say that keeping the mechanism of injury in your mind at all times is very important, because even though it's not obvious on this chest X-ray, it's still very much a possibility given the extent of the height that the patient fell from. So this is the chest X-ray, or sorry, the pelvic X-ray that was obtained following our secondary survey. At this point, I'd like to stop and get some comments from the audience. What do you think is going on with this pelvic X-ray here?
That's great. Let's start, Dr. Kasim. Any thoughts on that?
It's abnormal, number one. It is a vertical disruption of the pelvic rim. You know, the trauma is coming from impact injury of both legs onto the ground. In other words, he didn't fall flat on his back. And although there are some rotations present, the right hip looks deformed. And now he may have intertrochanteric fracture there. And obviously the right and the left hip joints don't look normal to me. And the pubic symphysis looks abnormal, and there may be some pubic rami fractures as well. All in all, there's major injuries present here, and it'll make me think the patient had severe injury to the pelvis, and immediately I will put on a binder.
Right, interesting. Dr. Aurelio,
Yeah,
any
yes, interesting. Yeah, I agree with everything they're saying. It's abnormal. I think in this moment, mechanism, I say SAP, lateral mechanism. What is the mechanism? Because that's, in sometimes, despite it's not 100%, help a little bit in the association between mechanisms and blood transfusion. The literature aguanta todo, we say in Spanish, So we see a lot of papers on many things. But also I'm thinking, this patient has this kind of fractured pelvis and everything else. I'm thinking already in my mind going, what I'm going to do with this. I'm going to do, you said the FAST was negative, right? And then I'm thinking that most of the bleeding, this patient is going to have bleeding possible in the pelvis, and the pelvis has to produce some sort of bleeding. I can't believe this patient has any bleeding in intrapelvic. And I'm thinking most of the bleeding in the pelvis are venous, no arterial. What I'm thinking also that arteriogram is going to help because everybody does arteriograms, but this patient probably needs compression of the venous plexus. We will talk about that, I'm sure. Go ahead.
All right. Dr. Semaj also, he's also concerned about the pelvic injury. He said that this patient belongs in the OR for pelvic packing, followed by angio switch versus a hybrid room. That's an interesting, because not all places have hybrid room available for these. And he also adds that this is an axial mechanism. So pelvic binder might not work well. So this is how we have to balance everything, right? And he also adds that pelvic and retroperitoneal hematoma are not peak picked up by FAST. That's very true. We have all we all been in this situation before. And also Dr. Franzon, he's saying that looks like the urinary catheter is out of the bladder. I'm not sure about that because of the material of the catheter, but it's interesting to have these different points, and we're sure very, very, very interested in seeing how this is going to develop. Dr. Gochi.
Thank you so much. That, everybody brings up really excellent points, and I think it puts me in a good position to continue onward to describe our case, because there's so much variability in what we can do. In just the last 5 minutes, we heard so much about different forms of management for pelvic fractures, especially based on mechanism and based on extent of hemorrhage. So for our patient, after they were given MTP, they were stabilized, and we were able to proceed to the CT scanner to get a better idea of the extent of these fractures and possible hemorrhage. So I'm going to show you here the CT scan, and I can keep playing it. This is abdomen down to pelvis. So as you can see here, we're starting to see the extent of these pelvic fractures, as well as potential active extravasation medially to where the injury occurred. And it appears that the Foley catheter is in adequate location. So at this point, imaging revealed, as you can see, multiple pelvic ring fractures, including the left iliac, acetabulum, and sacroiliac fractures, with active extravasation from the left hypogastric artery, as you can see here. So at this point, I just want to quickly review the different sort of pelvic fractures based on the Young-Burgess classification. I did hear, some of the prior attendings talk about lateral compression, AP compression, vertical shear, and these are basically classified based on where the impact of the force comes from. So in lateral compression, it's usually caused by side impact forces. The pelvis is internally rotated, and if it's often closed. So in these fractures, a binder doesn't really help with any hemorrhage. It can potentially worsen displacement, as you can see here, the fracture patterns. In the AP compression, or the anterior posterior compression, or open book, these respond very well to a binder because the pelvic ring, as you see, is widened. And so we can physically reduce the volume of the pelvis with compression around the pelvis. And then in vertical shear, this is usually an injury that causes a hemipelvic displacement vertically and rotationally. And these also don't really respond well to binders because the shear force is axial. It's not horizontal, like in the case of AP compression. And so in this case, the binder won't really provide stability. Rather, we need definitive fixation. And the last type is a combined mechanism where you could potentially have different elements of AP, LC, vertical shear. And in those cases, a binder may or may not help. It just sort of depends on what the major, what class is sort of leading that fracture pattern. And this video just shows a 3D reconstruction of our patient and his pelvic injury. We believed him to have a vertical shear fracture pattern. So in our case, as mentioned, our patient had vertical shear fracture, a pattern that doesn't really benefit from a binder placement due to its axial instability. Instead, we focused on resuscitation. Once the patient was more stabilized, we made the decision to take him to the OR for hemorrhage control. I will say also that, as you all previously picked up on, this patient also had traumatic brain injury. And so while in the OR, the patient also had placement of an EVD by neurosurgery after the exploratory laparotomy that was performed.
Andrea, excuse me, I interrupt you.
Yes.
Do you mention? Oh, I am, because I'm 82. I am like a Biden. Do you mention by any chance the CT of the chest, or you on purpose you hiding that part for the end?
On purpose, I'm hiding that part right now.
Oh, okay. I'd let you the mystery. Okay. One thing I want to just make a comment. Dr. Burgess, Andy Burgess was a young attending with me. We argue every day, okay? We didn't get along very well. We had the same personality. So I know about his classification. Was a young radiologist. So I know the history of that. So I'm impressed about it. I read about the association between the binder, if it's AP, if it's lateral, if it's shear. Uh, to be honest with you, at 3 o'clock in the morning, I cannot tell you. I never learned in shock trauma how to read a CAT scan because we have a radiologist 24 hours every minute, attending radiologist. So he can tell me not only what kind of fracture, he tell me what kind of surgery I should do. That's where. So I never learned that. So probably I just put a binder, But I'm learning of this, that if it's this, don't use this and use the other one. And knowing the owners of this, the classification, then I start having my doubts. But go ahead.
Thank you.
Gochi,
yes.
What did you find in the head CT scan that prompted the neurosurgery guys to do a EVD?
So he had evidence of multiple skull fractures as well as fractures at the base of the skull. He had pneumocephalus and findings of a subdural hemorrhage. And so the primary reason that they wanted to place the EVD was for decompression and also to monitor his ICPs during this time.
All right, that's great. All right.
Okay, so continuing with the OR, he underwent an exploratory laparotomy. The OR findings are shown here, but I do want to highlight that they found evidence of non-expanding zone 3 retroperitoneal hematoma, as well as grade 1 splenic laceration. There was a 5 centimeter grade 1 mid-transverse colon injury that was primarily repaired. And at this time, the patient was hemodynamically stable. There were no signs of active hemorrhage. And so the decision was made to pack him and to transport him to IR as quickly as possible. So in the IR, he underwent angiography and he had embolization of the left hypogastric artery with gel foam, and this achieved hemostasis.
Can I ask a question? What took you, maybe I missed because I went to a place you can know with me. Where is the missing here? Why do you decide to go to the OR? This was deteriorating in front of you? It's because the CT showed many blashes? What was the indication to take him to the OR immediately?
Yeah, so, because the patient was minimally responding to MTP, he was hemodynamically stable to go to CT scanner, but then he still was becoming hypotensive. So he was taken to the OR.
I missed that part.
Okay, thank you for asking the question.
Dr. Anders, can I ask a question? You decided to go to the OR because the patient was minimally responding to your MTP, and you became suspicious that he may have intra-abdominal bleed and we need to go after it. But by that time, did you complete a thorough investigation of above the diaphragm, below the diaphragm, to make sure that he was not bleeding anything anywhere else, such as above the diaphragm, so that you could have said, hey, he may be bleeding above the diaphragm. I need to rule that out by either CT scan or another modality of investigation. And I'm thinking of transesophageal echo. And so that you could confidently say, I'm going to do a laparotomy because I'm going to find something bleeding there, instead of doing a laparotomy and find nothing so dramatic as you found, and then you packed it in and went to the CT.
Yeah, thank you so much for that question. So we did get CT imaging of the patient before going to the OR. He had CT head, CT C-spine, CT chest, CT abdomen, pelvis. So based on the findings of the CT chest, we knew that there was no active hemorrhage in the chest.
Okay.
What do you mean? I want you to tell me, your aortic, no, the aorta and the chest was normal contour and no periaortic hematoma, who are the two signs of rupture aorta. So you're telling me there was negative, there was no rupture aorta and CT. That's
There
correct?
was no ruptured aorta on the CT, correct.
Amazing. So, because if you have a doubt, this was your opportunity at the same time that you did the angiogram for the belly, they can angio the chest, if you have a doubt. That was the old days, But now people, the CT are so good that it's unlikely it's going to be normal with a rupture aorta. Go ahead.
Thank you. I appreciate all these excellent questions.
Hey, Andrea, I had one comment and question. So since you had a CT scan preoperatively, was there anything on the CT scan that you think indicated abdominal exploration as opposed to preperitoneal pelvic packing?
He had that evidence of hematoma and active extravasation, where that warranted further exploration. In regards to preperitoneal packing, it's my understanding that at our institution, we're sort of recommended that if the patient's hemodynamically normal and they can go to IR to avoid preperitoneal packing. And the reason for that is because of the risk of infection and osteomyelitis. And at this time, that's the recommendation from our orthopedic surgery department.
So you follow the orthopedics, what they're telling you, they're telling me, I don't want to hear that. Okay, go ahead.
Dr. Gutierrez, did I answer your question?
I'm just saying, I think the pelvic findings are, reasonable if the patient's unstable to do preperitoneal pelvic packing, either via fan and steel incision or a lower midline incision. But if you have a CT scan and you know there's not major hemorrhage in the belly, why go into the belly? Why not just do a fan and steel and do packing and then get the patient to the OR? Or excuse me, to IR.
Mm-hmm. Well, I think the decision to go to the OR was based on the patient's hemodynamics. And I think the operating team wanted to ensure there was no significant intra-abdominal hemorrhage before proceeding to IR.
You had a CT scan, right?
Mm-hmm.
Yeah, I mean, there's no doubt the patient should go to the OR, but the question is, what incision are you going to make in the OR? Are you going to do a midline laparotomy for, abdominal exploration, or just do preperitoneal pelvic packing? Given that you already know there's no significant hemorrhage on CT in the abdomen, but there is in the pelvis. You see what I'm saying?
I do. Unfortunately, I wasn't there to be a part of the decision-making process, but I completely understand what you're saying.
Things can always change, and you can do like a quick laparotomy to rule it out, even if you do have imaging. But I think unless there's massive hemoperitoneum upon getting in, if there's not much or just a small ooze, I would focus on the pelvis and prioritize that.
Thank you, Dr. Gutierrez.
Yeah, it makes sense.
So following the patient's IR procedure, about 6 hours later on post-op day 1, orthopedic surgery was able to place application of a distal femur skeletal traction for the pelvis. And they also provided recommendations for a right upper extremity scaphoid fracture. At this time, they wanted to wait until the patient was more stabilized before proceeding with any definitive fixation of the pelvis. And now I'd like to move on to the CT chest, which is what I think everybody has been waiting for.
I like to emphasize for the younger guys that don't forget the most common cause of bleeding intrapelvic is not arterial, is venous. That's why the package is important because it's a pre-sacral a bleeding venous and pre-vesical venous. That's what some people does that before. It's a bridge between going to angio is doing that first because angio is not going to solve the problem. And you cannot embolize the vein, as far as I know, at least 8 years ago. Okay, go ahead.
Thank you so much. So now I'd like to turn our attention to another important aspect of this patient's injuries and his care. As you can see here, this is the patient's initial CT chest that was obtained when we obtained imaging at the very beginning. We did identify a traumatic injury of the proximal descending thoracic aorta, and this was consistent with University of Washington moderate grade and Society of Vascular Surgeons grade 2/grade 3 blunt aortic injury. I do want to note that our vascular surgery team was consulted intraoperatively, and at that time, the consensus was that because it's stable and it's contained, given the patient's multiple other competing priorities, the decision was made to defer TVAR until the patient was better stabilized. I want to briefly go over the 2 different criterias and how.
Yeah, I'm sorry I interrupt so much, but this is an area that I like. Well, I was doing that all my life. I'm telling you that I never saw this CT sidewise. All the diagnosis, I was taught, and I treat everybody, that there's 2 signs, a rupture aorta and the CT flat, no this lateral one, is the lack of contour and normality of the aorta, number 1. And number 2, secondary periaortic hematoma is not 100%. But if the aorta, contour is abnormal, the patient has a ruptured aorta. Now, I want to emphasize before I forget, because I forget everything, that what you see in the CT is not what you're going to see when you operate the patient. There is no 100% correlation. Sometimes this is small, and I'm going to see this classification, which is very interesting, like a grade 1 who is like being, minimally pregnant, a minimally rupture. I don't understand that, but go ahead, do your classification.
Thank you. So just very briefly touch upon these different ways to classify blunt aortic injuries. The top, as you can see, is from the Society of for Vascular Surgery, where they divide grades into whether it's a small intimal tear, intramural hematoma, pseudoaneurysm, or a rupture. And typically, this allows you to determine the sort of management that you want to proceed with in these kinds of injuries. So for lower grades, oftentimes it's medical therapy and follow-up imaging versus grade 3 and 4, which definitively requires intervention. The Harbor View or the University of Washington grading system is more radiology centered. Type 1 or minimal involves a small intimal flap that is less than 1 centimeter. Moderate grade involves larger flaps or an intraluminal thrombus, as we previously heard, as well as whether there's a contour abnormality or a pseudoaneurysm. And the severe classification is active extravasation or free rupture. And so this system is useful early on because it allows trauma teams as well as radiologists to decide how urgently intervention is. And so I do want to highlight that both of these classifications can be used to complement each other as opposed to be used one exclusively over the other. And that's how our vascular surgery team defined the aortic injury present in our patient.
So it's my understanding that you vascular surgeons are the one involved in the aorta rupture, correct? Because I am from the era before stent. So the vascular surgeon never in their life saw a rupture aorta in their lives, you know. We thoracic surgeons or trauma surgeons, like in Colorado, repair the aorta. We didn't call the thoracic surgeon to do a vascular surgery. So this is a new era, but I would like to emphasize something. You know, the major trauma centers, we in shock trauma saw 10 aorta ruptures a year, 5 for the other thoracic surgeon, 5 for me. So when I'm trying to explain to you, all these people do these classifications, I wonder if they ever did or saw the real rupture aorta. They are vascular surgeons who put a stent usually, right? They are the people who put a stent. So they see stents. So anyway, I am, it's very hard to come to a conclusion. And after so many cases I lost many, I saved a lot. So what I'm trying to say, there was no disclassification. Actually, the guy who started this was one guy who did moonlight for me as a thoracic surgeon, moonlighting and trauma in Little Hospital when I was working. So I know the story of these classifications, you know. So I want to take a grain of salt, but it's important what you're saying, because one of the things you say is very important. There never was a way to know, can I wait a little bit longer? Or this can rupture in a minute. That point I like it, because I get it. I said, yes, we can do other things, give it something to drop the blood pressure, let's take care of the other things. They take care of the pelvis. But in this case, you're telling me these people, who I don't know who they are, can tell you if it's this grade 2.5 or 3.5, then you can wait. You can wait 10 hours, 3 hours, or 4 hours. That's exciting. It's exciting medicine. Go ahead.
Oh, Dr.
What more?
Rodriguez, could I interrupt here? This is Dr.
Yeah.
Mendoza.
Yeah.
You know, I'm interested to hear about your clamp and sew past. So in the patient who is hemodynamically stable, like this patient, with this very tiny diminutive injury, what would you do in the past? When would you consider clamp and sew? And did you put these patients on bypass when you did?
Yeah. Señora Mendoza, that's your Spanish name, or you are married with Mendoza? Anyway.
No, this is my name. My family's
So
Cuban.
you're a real Mendoza. Okay,
Yeah, I'm
Señora
real. I'm
Mendoza.
the real deal. Yeah.
Señora Mendoza, you know, you can, but a little bit derogative. You are from the Tropping Club. Yes, yes. I am from that time. I don't remember all the cases I did. I ever used the pump. Despite I was trained as a cardiothoracic surgeon in Wayne State. You know, I didn't use. But so for me, it was no. I cannot tell in my experience what I put a pump, what I don't put a pump. We were at the time when we have any abnormality in the aorta, we intervene. That was an excess, correct? That's what we did so many cases, you know. But what I found is something interesting, was trying to emphasize that what you see in the CT, in the angiogram, the picture did not correlate what I found it. I saw a little lump, a little thing abnormal, that's what we operate. If when I opened, was totally separated the aorta. Was it? I expellation, body expellation. My God, if I trust that, the patient was going to blow out. That's my experience, okay? No read on any place, because as you know, I'm politically incorrect. Go ahead.
All right.
I like it. Dr. Gochi, continue.
Dr. Marigoso, you were thinking for why Rodriguez was invited. Okay, I'm sorry. I'm here.
No, no worries. Dr. Gochi, you are muted.
Sorry, I said thank you, Dr. Mendoza, and thank you everyone for that excellent discussion. Really appreciate all of your insight into making this a very active discussion and grand round. So I appreciate all of you. You know, as we were talking about the usefulness of this grading system and this classification system, it does allow us to determine which patients need immediate intervention versus which we can delay. And so in the case of our patient who had grade 2, grade 3, the decision was made to delay their surgical intervention until all of the other injuries had been managed and stabilized. And so this decision is also supported by a recent retrospective study that was published in 2021 in the Journal of Vascular Surgery, where they examined outcomes in patients with grade 2 to grade 4 blunt aortic injuries. They found that delaying TEVAR, typically beyond 24 hours, was associated with a significant reduction in in-hospital mortality. And the rationale is that delaying allows time for hemodynamic stabilization, correction of coagulopathy, and prioritization of other life-threatening injuries, like in the case of our patient with his active hemorrhage and intracranial trauma. I do want to note, however, that this does not apply to patients that have grade 4 blunt aortic injuries with rupture that are actively bleeding. This would not apply in that situation. So our patient ended up undergoing TEVAR, hospital day 5, without any complications. And this is an image taken from his aortic grouping. And so my summary slide is seen here. Our timeline of our patient presentation shows a full trajectory of this patient's resuscitation and care, all the way from when he arrived to the trauma bay, underwent OR intervention, IR intervention, had traction placed by orthopedic surgery, and underwent TEVAR. This is the extent of all the patient's injuries that I wanted to highlight for you all, so you can get a sense of all of the significant injuries that this patient unfortunately had after their fall. I'll just let you take a moment to review the injuries, but he was very injured. And lastly, a few clinical pearls I want to leave you with. Whenever you have pelvic fractures, you should have very high suspicion for vascular injuries, either venous plexus or arterial injuries. Resuscitation will allow you the time to determine how to proceed with intervention for the patient. And if you have a patient who's undergoing active hemorrhage, then you're going to need definitive intervention, either in the OR or in the IR suite. And lastly, another important takeaway is that depending on the grade of the aortic injury, it could potentially be delayed once the patient has been adequately stabilized and resuscitated. And with that, I say thank you, open up the discussion to others to talk about what else we could have done. But that is the conclusion of my presentation. Thank you.
That's perfect. Thank you very much, Dr. Gochi. Dr. Kasim, any final comments for this case? I think you're muted, Dr. Kasim.
Sorry. That was a very good presentation by Dr. Gochi. I enjoyed that very, very much.
Thank you.
And I like the way that you went about in your own mind, how you approach this case and the rationale for delaying the aortic injury and attending to the immediate need for stopping the bleed in the pelvis. And I think you did everything just right. My thoughts and conclusion in this case is, I would have done, after the CAT scan, I would have done transesophageal echo. I think it'll give me a little more information, actually the tear that I'm looking at on the angiogram. They say anything less than 10 millimeter can be watched carefully, and above 10 millimeter, you need to get ready to do some type of repair. And I once attended a symposium on this at UCLA, and they are of the same thought as you presented. They do not rush into doing immediate repair on thoracic aortic injuries. They take their time, and their results are as good as anybody else. All in all, the case that you presented has given me educational impetus, and it is nice to hear somebody like you presenting a case so succinctly, clearly, with objective backup with images, etc. I enjoyed it very much. Thank you so much.
Perfect.
you.
Thank you, Dr. Kassim. Dr. Rodriguez, any final comments for Dr. Gochi and her team?
I want to emphasize what Dr. Kahim said. You were marvelous. Your presentation was excellent. Your support there with Dr. Mendoza was there. Call me a clump and sew surgeon. Thank you, Dr. Mendoza. I was there because we were macho mas in those days. There were no options. And the other thing I want to say, very interesting. You know, in the old days, we believe in this. It was based, no, the classification was based in cadavers. They came to the conclusion, if you wait X number of hours, is X percentage of rupture. If you wait more than 5-6 hours, the patient is dead. So we thoracic surgeon for those days, you had this classification, which I don't know if it's true or not, type 1, type 2, type 3, whatever. I would like to know, I had to read that. The vascular surgeon write, you know, there is a lot of people and that write things and they don't do things. So, you know, I want to be sure, where does this classification come? I guess they did a multi-institutional, correct, Doctor? This classification, because from one single institution, remember, the most common, the most busy time was at that time 10 a year for shock trauma, you know. So I don't know how many one single organization is going to come. I'm sure it was multi-institutional. So conclusion, it's very nice to have now this classification. They say you can wait, you cannot wait, except, you know, the lawyers will be waiting there. You wait too much and the patient blow out. But you have to be careful with that. And the other point is, remember that in the old days, where we have pelvis fracture, okay, and we have a rupture aorta, so see, we don't have this classification, grade 1, 1.5, 2 classifications. We did is, the orthopaths put a Hoffman external fixators, you know. We didn't have even at those days the peritoneal packing. We did angiogram. Actually, well, no CT. Our diagnosis was done by orthography. And they turned the patient over the Hoffman sidewise and repair the aorta. But this, obviously, the life is much easier for the surgeons these days with all this classification that justify they can wait a little bit. But one thing I read recently, they're questioning the angiogram, you know, when you don't need it, because in the best center, sometimes it takes many hours to have an angiogram. So you have to consider that other option versus the angiogram. I keep insisting, I know nobody wants to insist on this, unless this is a lie in the books and the literature, that the most common bleeding from the pelvis is not arterial, it's venous. That's what the preperitoneal packing is very useful as a bridge between you arrive of the patient where you seat belt, whatever you don't want, the sheet, you know, the preperitoneal packing, and then go to angiogram if it's necessary. Thank you very much. This is very, very, I think, a more challenging that I have case. You have a patient with head injury. Nobody talk very much. Head injury, rupture aorta, and pelvis bleeding. Thank you very much. Outstanding.
Excellent. Thank you, Dr. Rodriguez. So, and I wanted to thank Dr. Gochi and Dr. Mendoza for presenting this case today. They were able to present this in very short notice, so that's why I really thank you for being here and preparing this case. It was really, really interesting. And I leave you, Dr. Gochi and Dr. Mendoza, for your final comments and to end this session. Thank you very much.
I apologize for coming late. There were some emergencies. I really wish I would have heard people's thoughts on the vertical shear pelvic fracture. It seems like many of you would have proceeded with pelvic packing. Is that correct?
Yes, what you didn't hear me saying is about the shearing. Since I am at the same time that Dr. Burgess was an young attending, young was a young radiologist, create this classification, and they start saying all this, the association with more transfusion, no transfusion. Since I was raised with them and argue with them, so I have my questions about all these classifications, and the gives or no. But obviously, the time has proved that what they're saying was correct. So I was wrong.
No, I disagree. I actually, this is, to be perfectly honest, this isn't my case. And I was taking care of the patient 2 days after this showed up, and I'm like, I would have pelvic packed this guy. But our orthopedic trauma director here feels very passionate about angio. He really does not want us to pelvic pack at all costs. But I totally agree with your sentiment. Venous hemorrhage is like 80% of the cause of pelvic hemorrhage. That's what they tell us too.
Correct. Yes.
So I fight with him. I'm like, this person needed packing. So I feel better. I feel justified. I'm going to continue to pelvic pack until this group tells me otherwise.
Yeah, another thing the residents should know that you cannot have blushing zero, and bleeding, and vice versa. You can have blushes and no bleeding. So that nothing in medicine is black and white. Only in the books, people who write who are false prophets.
Well, we're beyond honored to be allowed to talk in front of this great, amazing group. I'm so honored to present in front of all of you, and I'm so happy that you guys thought the case was interesting. Dr. Gochi, I'm so proud of her. She's our research resident here. I will let her have her final thoughts, but thank you everyone for allowing us to present today.
I just want to echo what Dr. Mendoza said. It's a real honor and privilege to be here presenting to you all and hearing all your excellent feedback. I really appreciate your time, your questions, the discussion. I think it went even better than I had hoped. So thank you so much for having us here today. And I hope that, we all take something away from today's presentation. Thank you. And thank you, Dr. Mendoza, for being an amazing mentor. And Dr. Beatty, who is also here, one of my other mentors. Dr. Gutierrez left to the OR. And Dr. Miraflores, she's our program director. Thank you all for being here in support.
Well, that's excellent. Everyone joined, so it was perfect. Dr. Gochi, feel free to join any other sessions and to present any more cases if you like in the future. Just we can keep in touch so we can make this happen. And anyone, if you are listening to this presentation, if you're still here, just send me a message or a email or anything if you want to present cases as well in these meetings. So just send me a text message or an email. We can schedule your presentation. And I hope to see you all very, very soon in Ecuador for the PTS meeting, and also seeing you guys in the next Telegram rounds on Mondays. Thank you very much. Bye-bye.
Thank you.